Thank you, Dr. Tobe, for coming in and helping us out. And it's the third time here, a very interesting topic that we are going to get off today. And I invite Dr. Kajuru, who's a senior nephrologist in Tanzania, in place of Dr. Egina. Today, Dr. Egina has to attend to his has a family issue, and so he couldn't join in. And so Dr. Kajuru has kindly agreed to actually chair the session. And over to Dr. Kajuru. Thank you for taking it on today at a short notice.
Yeah, so Professor Sheldon Tobe is a professor of medicine at the University of Toronto and also at Northern Ontario School of Medicine. And he's been around in the field since 1985, and he's quite, his interest is in heart failure, hypertension and the effects from the heart and the brain. So has a foundation, the Heart and Stroke Foundation, among the Aboriginals and rural health research. And so he's also interested in disparity in care. His clinical activities focus on hemodialysis and patients with CKD. And his main research interest is implementation science. And he has been the chair of the Canadian Hypertension Education Program from 2005 to 2012. He's also a co-chair of the Canadian Cardiovascular Harmonized National Guidelines Endeavour, so C-Change. And he's also the board of directors of the American Society of Hypertension Specialist Program. So it's been a while for the past 25 years and has received many teaching awards and so other career distinctions. So we're very, very happy to hear more from him today. So Prof, you're much welcome.
Sure, thank you. And it's a great pleasure, and thank you for the kind words. So exciting to be introduced by you. I'll just share my screen. And today we're going to talk the last of the three series, the last of the three sessions in the series is about protecting the hearts in patients with chronic kidney disease. There we go. Okay, does that present okay on your screens?
Yes, that's great. Yeah.
Very good. And again, C-Change is a overarching guidelines group, Canadian Cardiovascular Harmonized National Guidelines Endeavour, that works with our other guidelines groups like hypertension, diabetes, renal, and so on, to make sure that the guidelines are harmonized amongst them. And we've developed each of these modules to support specific recommendations in the guidelines. And the goal with the modules is to be able to train the primary care community, internists, and family doctors, nurses, nurse practitioners, pharmacists, and so on, to help practice according to our clinical practice recommendations and to help improve outcomes of patients. And I really appreciate that you're participating in the last 3 weeks. And I know that you are gonna, I'm hoping that the information that I've been talking about and the cases that I've been using, and you're welcome to use them yourselves, will help you to teach the clinicians that you're working with. And that's how we create a really great impact. You teach 10 clinicians, and those clinicians then help 10 patients each. It has an absolutely massive ripple effect. Thank you to all the members of our Scientific Education Committee and lots of family docs and nurse practitioners as part of that, to help make sure that our message is appropriate for the primary care community. I still have a couple of conflicts with respect to pharmas. Sorry, so this is not my slide. With Bayer for the finerenone studies that are just completing, Fidelio and Figaro, and with all the companies at the bottom of the slides who have helped to sponsor some of these sessions that I help to facilitate in Canada. In fact, we're now providing some of the sessions in French. And if you want to work on a Swahili version, just let me know. That would be very cool.
Oh, that'd be wonderful. That'd be wonderful, Dr. Tobe. Thank you.
This is Donald. And today's case is about Donald, who's was a patient of mine, still is a patient of mine. And he participated in one of our studies, as I'll explain. So he was a 55-year-old man, he's older now, had a left nephrectomy and hypertension, and came to see me in the office. So our learning objectives with Donald are how to identify a patient with chronic kidney disease and to formulate a plan for both renal and cardiovascular risk reduction. Often as nephrologists, we tend to be renal centric and forget about the heart, but really our patients are at much greater risk of cardiovascular disease than progressive renal disease. So we're going to focus on blood pressure management, cholesterol management, and the role of this new class of drug, SGLT2 inhibitors, for patients like Donald. And then how to transmit that information to him and how to talk to our colleagues about this management so that they are best able to incorporate it into practice. So I always like to start with a question, and if you could put in information into the chat about your greatest challenge managing patients with chronic kidney disease. And I'd like you to think about the challenges with respect to cardiovascular management. Yeah, David, polypharmacy. So we're talking about adding medication, adding medication, adding medication. Just as we were in the last sessions talking about managing diabetes and so on. And it's quite a challenge to have our patients accept taking so many additional medications, and often they are resistant to that. Yes, and getting them to accept the therapy, it's also quite expensive. So if there's not a healthcare plan to provide, a pharma plan to provide medicines for them, finding enough medications, making them into single pill combinations to reduce the pill burden. Dose adjustment is also quite challenging, and many drugs have to have dose adjustments, particularly antibiotics. And but the meds that we're going to talk about today are fairly straightforward, fortunately, for terms of dose adjustment in chronic kidney disease. And yes, refractory hyperkalemia. So this is quite limiting in terms of our ability to use ACE inhibitors and ARBs. And we'll pick up that theme again. It's not part of today's talk, but as we talk about ACE inhibitors and ARBs, to talk about the newer agents for managing hyperkalemia. And in particular, patients who have diets that are high in fresh fruits and vegetables, they're going to run into potassium problems. Good, let's go ahead. So here's Donald. He's 55, and he's got this remote nephrectomy, had a renal cell carcinoma, and it was removed. 5 years later, he's doing just fine. But his creatinine is elevated, and he's moved, and now he's come to your office for a review. He was in our study, the SHARP study. And I don't know how many of you remember the SHARP study, the study of heart and renal protection. And Lloyd, that study was ongoing when you were in Toronto. And it was quite interesting that when we started the study, my colleagues felt that lowering cholesterol in patients with chronic kidney disease was a bad idea, that we shouldn't do it. And they didn't want to recruit patients into the study. And then by the end of the study, they felt that lowering cholesterol was a good idea. And they didn't want to recruit patients into the study who might end up on placebo. That's how you know that the study is necessary. We did quite well in our recruitment, and SHARP completed in 2010. So Donald wants to know if the results of the SHARP study applied to him and if he should now be on therapy. So his blood pressure has been controlled on a CCB and an ACE inhibitor for 10 years. And at the time, the guideline for blood pressure management in patients with chronic kidney disease was targeted to less than 140 over 90. And that's where he was. He's a non-smoker and just uses alcohol socially, separated, and has 2 adult children. His father passed away at age 58 from a stroke, no doubt, with a history of hypertension. His mother also has hypertension, and all of his brothers, older brothers, have hypertension and also histories of cardiovascular disease. So he has a rich family history of hypertension and cardiovascular risk. Here are his meds, good medications. Not sure why he was on aspirin. And on his examination, he's trim, a BMI of 24. His blood pressure, 128 over 82. And this is with an automated device, unattended. So think to yourself, is this high blood pressure or not? And the rest of his exam is unremarkable. So here's some lab tests. And so he finishes the SHARP study in 2010, and then we have up to 2017 when I made the slide deck, and Donald is still doing well. His creatinine then was 157, very stable over time, 155 7 years later. You can see it fluctuates up and down a little bit. So in British units, we say American units in Canada. So the creatinine would be about 1.8, 1.9. And his hemoglobin is nice and stable. His A1C is creeping up. ACR is 20, and his EGFR is 52. So how do we classify chronic kidney disease? Just a reminder, we have 5 stages, G1 to G5, and this is the classic KDIGO classification scheme. And here we have stage 3 broken up into A and B, but in general, GFR of 90 to 120, 60 to 90, 30 to 60, and then stage 3A and B. Stage 4, when nephrologists like to see their patients, GFR of 15 to 30, and then it's time to start thinking about dialysis or transplantation or conservative measures when the GFR is down below 15 mils per minute. And Brenda Hemmelgarn expanded this classification scheme in 2010, which is published in 2012, by adding 3 levels of albuminuria: normal, and then what we used to call microalbuminuria, and then macroalbuminuria or overt nephropathy. And you can see the new terms that I put in here because endocrinologists could not pronounce those terms. So now we have normal to mildly increased, moderately increased, and severely increased, right? And there's the levels. And I think in the units you're familiar with, 30, less than 30, 30 to 300, and greater than 300 milligrams per gram. The heat map is both a heat map for progressive chronic kidney disease. Those of us, I hope all of us are in the normal range, with normal GFR between 60 and 120, and normal albuminuria. But as soon as we develop albuminuria, even with normal GFR, there starts to be an increased risk of progressive chronic kidney disease, as well as an increased risk of cardiovascular disease. And as the GFR falls, even with normal albuminuria, the risk of renal progression increases, as does the risk of cardiovascular disease. And when we add both, we get to the highest risk quite quickly. And I'll show you some actual evidence of that. So you meet Donald, his blood pressure is 128 over 82. You think to yourself, boy, is his blood pressure under control or is it not under control? So based on the new Sprint blood pressure recommendations, in Canada at least, and what is his blood pressure target? So if you're thinking American guidelines, AHA, ACC guidelines, you'll come up with a different answer. If you're looking at European guidelines, they're a bit all over the place for chronic kidney disease. And in Canada, we have a very specific recommendation. So go ahead, put your letter into the chat, And okay, oh, lots of people know the Canadian guideline. Very good. All right. Very good. Very, very good. So I was in charge of the chronic kidney disease subgroup for the Canadian hypertension guidelines for many years. And I took the recommendation, we initially said less than 130/80, then we moved it up to less than 140/90, and now it's less than 120. So all of these have been correct over time. And data from the ASK study and the RAIN-2 study, which actually studied less than 130/80 versus above, the RAIN-2 study had to be stopped for futility, and the ASK study did not demonstrate better renal outcomes with that lower blood pressure target. And RAIN-2 also was looking at renal outcomes and not cardiovascular outcomes. That was my contribution to that subgroup back in 2000, 2001, that I said that kidney outcomes were as important as cardiovascular outcomes. But for a renal target of blood pressure, it actually led us on a route that didn't get us the right answer. None of those studies were powered for cardiovascular outcomes. And it turns out that the SPRINT study, which oversubscribed patients who have chronic kidney disease, to help answer the question about is intensified blood pressure lowering in high-risk patients beneficial, found that a blood pressure target of less than 120, intensified blood pressure lowering, led to better cardiovascular outcomes than a target of less than 140/90. And it was quite remarkable. Now, the renal outcomes were not better with a target of less than 120. And what was happening in SPRINT is that intensified blood pressure target was just like starting a patient on an ACE inhibitor or ARB. It lowered intraglomerular pressure, so the creatinine actually rose up to 30% in patients with intensified blood pressure lowering. So to get into SPRINT, patients had to have high cardiovascular risk. CKD was one of those risks. So they could have proteinuria or a GFR of 20 to 59. And a GFR of 20 to 59. If they had more than a gram of proteinuria, they couldn't come in. If they had PKD, they couldn't come in because that HALT PKD study was a sister study to SPRINT. They could get into SPRINT if they had a high cardiovascular risk, 15% or greater, or just being age 75 and above. So our recommendation became, in Canada, for high-risk patients, like Donald, targeting a blood pressure of less than 120 systolic. And that's primarily for cardiovascular risk reduction. And we know if our patients have a healthy heart, their kidneys are going to do better. So are there any questions about blood pressure lowering in patients with chronic kidney disease? Now, I'll just go on a little bit about blood pressure lowering in CKD, in case, I'm waiting for some questions to come up. And in the United States, with the ACC AHA recommendation, is a target of less than 130/80 for everybody. So it doesn't quite follow the evidence for chronic kidney disease, for example, but the simplicity of that target is brilliant, where you can tell a huge country, let's just aim for less than 130/80 in everyone. And okay, so we're not getting less than 120 in patients with CKD. We're not missing a whole lot. And maybe some patients who've had a stroke are, in Canada, we would say less than 140/90. But in the US, it's still less than 130/80. I'm sure there's no harm done in lowering their blood pressure a little further. I think the simplicity of their approach in the States is very cool. And in Tanzania, I think you're following the World Health Organization blood pressure. And yes, so a target of, if you target less than 120, that's still less than 140/90. So there's nothing wrong with that. If your patient's feeling well, then that is great. But if they're feeling weak or dizzy, it may not be appropriate for your patient. And again, a reminder, guidelines are signposts. They're there to help us manage the patients, but not to handcuff us in what to do. And you know your patient the best, and please tell your trainees and your colleagues that they know their patients the best, and our expectation is that we can tell them what the recommendation is for an individual patient, but that they would manage the patient to the best of what that patient needs.
Question from Rwanda.
Go ahead.
Question from Rwanda. Dr. Joseph Ntarengwa here speaking. Now, does this blood pressure of less than 120 apply even if the patient had a blood pressure? Was above 65 years of 60 years of age? Because in most guidelines, they say it is safe to keep the target blood pressure above 150 systolic if the person is above 60 years.
Yeah. So the SPRINT study specifically enrolled patients, over-enrolled patients age 75 and above, and also there's a sub-study looking at frailty, and the older patients did just fine with the blood pressure lowering. They did not have any additional injurious falls, for example, subdural hematomas or broken hips. Then the intensive group did not have more injurious falls than the standard of care, less than 140/90. And even in patients who were frail, they continued to show a benefit for reduced cardiovascular risk with the intensified blood pressure lowering, and actually had an increased absolute risk reduction the more frail they were. So age should not be a barrier, but dependent on your individual patient, of course.
Is there any subgroup of patients who may be at harm at using a systolic of less than 120? Any subgroup, like a vasculopathic group or something like that? Is there any way we can identify a subgroup who may have problems with a systolic less than 120? Sure.
So I would, the contraindications for being part of the SPRINT study, they include postural drop in blood pressure when the patient stands up, being in a nursing home, patients who have renal vascular disease were excluded, patients with stroke were excluded from the study, as were patients with diabetes because of the ACCORD study. That was another sister study. So those patients were not included in SPRINT, so we would not have that very low, that intensified blood pressure target for those groups.
Thank you. Thank you.
Not for Donald, he would fit. Okay, so we've intensified his blood pressure lowering. And I should say, what drug would you add to him? He's got he's on a CCB and an ACE inhibitor. And what additional therapy would you give him to bring his blood pressure under control? There's his meds.
Oh, a diuretic?
Now his A1C is 6.4%, biased by studies.
SGLT2.
SGLT2, oh. So I do believe that SGLT2 inhibitors do lower blood sugar. Sorry, they lower blood sugar. They also lower blood pressure a little bit, but they're not going to bring Donald's blood pressure down low enough. So he's already on an ACE inhibitor. An ARB will do the same. The combination of ACE inhibitor and ARB do not provide better renal protection, do not provide better global cardiovascular risk. They do increase the risk for postural hypotension, acute kidney injury, as well as hyperkalemia. Yes, we recommend it. Sorry, Lloyd?
I presume his salt intake is fine. I mean, according to guidelines, 2 grams per day.
Excellent. Adding some sodium restriction is the same as adding a diuretic. Very effective to help bring his blood pressure down. Yes, and I would like to add a diuretic. That's if we needed an additional medication, I would add a thiazide diuretic, a long-acting thiazide diuretic like chlorthalidone or indapamide. And that often, particularly endocrinologists, seem afraid to add diuretics because it increases the blood sugar. And it does. It will increase the blood sugar by 0.2 or 0.3 on an A1C, but the overall benefit to the patient at achieving lower blood pressure is much greater than the risk of increasing the blood sugar. And we'll get to SGLT2 inhibitors later on. Is there any question about combining an ACE inhibitor and ARB together?
Yes, there is, because you'll have hyperkalemia. That's a subgroup of the Salimis trial. I forget the name now.
On target. In fact, we're going to show some on
target.
target data very soon.
Yeah.
Excellent.
Yeah, I think there are some past studies that, in fact, that combination actually, they suggest it should be avoided because they decrease creatinine doubling time. Basically, they increase the progression of kidney disease. I mean, talking about using an ARB and ACE inhibitor at the same time.
Yeah, so the on-target study, as we'll talk about in a few minutes, did not demonstrate a worse progression to end-stage renal disease, but there was a 5% incidence of hyperkalemia and an almost 2% incidence of acute kidney injury because of increased volume events. Yeah, so we want to avoid that. And didn't lower blood pressure anymore and didn't provide any renal protection. Okay, let's switch gears and talk about lipid lowering. So the SHARP study did demonstrate that treating the patient, lowering their cholesterol, reduced global cardiovascular risk. And this patient, does he have to worry about his cardiovascular risk? And as I mentioned before, yeah, he's at high risk. And the Canadian Cardiovascular Society now recognizes that patients who have a GFR less than 60 or a normal GFR and albuminuria are at high risk. So these patients are now considered high risk and are indicated for statin therapy and LDL lowering. And that includes both patients with preserved GFR and abnormal albuminuria, so ACR of 3 milligrams per millimole or 30 milligrams per gram, and low GFRs, or that's one group, or low GFR. How prevalent are these conditions? This data comes from a combined study between Canada and the United States. There's Joe Koresh looking at the NHANES data, and Amit Garg from London, Ontario. So most of us live in this region here, all of us here on this call, I hope. Normal albuminuria and normal GFR. 7% of the adult population, this is North American data, have abnormal albuminuria and a normal GFR. And 5% of the adult population have a GFR less than 60. And of those, 5% have a GFR of less than 60 with normal albuminuria, 2% have a low GFR and albuminuria, making another 7% who have a low GFR. So that's quite a lot of adults who have chronic kidney disease by this classification. So elevated ACR with normal GFR or a low GFR, so 7% and 7%, that's 14% of adults have some form of chronic kidney disease and are considered high risk from a cardiovascular perspective. That's quite a lot of patients. These patients are high risk. You know that because you see them in emergency all the time. They're in your hospitals, and these are the ones that are progressing and having an increased risk of cardiovascular disease. How do we calculate the GFR? We use the CKD epi formula. Now there's some question about designating a patient of African origin. People of African origin have increased muscle mass, so higher creatinines. But there's now some concern that that may disservice people of African origin by making their eGFR not quite as low as it would be otherwise. So there's a push underway now to take out that that factor, that fudge factor, for people of African origin in the CKD epi formula. So that's I'm not sure where that's going to go or if that's going to get traction. It is low. So he's asking whether he should be on lipid therapy after the based on the results of the SHARP study. And the SHARP study did change our clinical practice guideline. Ooh, wow, thank you. Validation studies in Africa removed the ethnicity factor. Thank you for that. If you could send me an, if there's a any reference for that, I would really appreciate that. So we're going to tell him that he's at high risk. Donald is at high cardiovascular risk. just because his GFR is less than 60. And here's some data to support that. This data comes from the Kaiser Permanente group in Northern California. And each of these three bar charts, if you look at the x-axis, it's GFR, normal GFR on your left, low GFR on your right. And on the y-axis is the rate per 100 person years of death, cardiovascular events, and hospitalization. And you can see for all three of these bad outcomes that the lower the GFR, the worse the outcomes. So low GFR is a cardiovascular risk. Here's some data from the OnTarget study, and I was an OnTarget investigator, and I pushed Dr. Youssef to do a sub-analysis on the role of chronic kidney disease and albuminuria and outcomes, and ended up with this publication and one of my favorite graphics. So the outcome of death in black and white on the left, and the outcome of ending up on dialysis in green on the right, and patients at the beginning of the OnTarget study who had a low GFR at baseline or a normal GFR at baseline, ending up on dialysis, a low GFR at baseline or a normal GFR at baseline, and then at baseline having normal microalbuminuria or macroalbuminuria. And on the y-axis is the percent of those patients in OnTarget who ended up either dying or ending up on dialysis. So the first thing you can see is that the risk of dying is greater than the risk of ending up on dialysis, quite significantly so. It's over 10 times as much. Now, even for patients who have macroalbuminuria and low GFR, they have an increased risk of ending up on dialysis, but look at how much higher their mortality rate is than ending up on dialysis. So the message for us is that our patients with chronic kidney disease need aggressive cardiovascular management. So that definitely applies to Donald. So patients with CKD, low eGFR, or abnormal ACR are at highest risk of cardiovascular events. Their high risk of death in cardiovascular events is much higher than the risk of renal events. Therefore, protect their kidneys, but also protect their hearts and their brains. Some people in the US still advocate both ARBs and ACEs, specifically in obesity-related FSGS and IgA nephropathy, despite OnTarget. What is my opinion? My opinion is that we have left them, those nephrologists a loophole in the guideline wording so that they can do that. But in the hands of nephrologists, it's fine. And I'll tell you about one of our own studies that demonstrated that. But we don't recommend it for non-nephrologists. So we did a study in Canada, I'm blocking on the name, where we gave candesartan to patients like Donald, to patients with or without diabetes with chronic kidney disease and albuminuria that had to have a gram of albuminuria despite maximal dose of ACE inhibitor or ARB. We put them on candesartan 32, and we randomized them to 32, 64, and 128 milligrams. Really high doses. And we followed them only for a short period of time, just for renal outcomes. And the proteinuria was nicely reduced with the 128 versus the 32. And there are really there's very, very little hyperkalemia in the 128 versus 32. Why is that? They're all nephrologists managing those patients. So because of that, we were able to build in a loophole so that nephrologists can use ACE inhibitor ARB. The benefit OnTarget really showed that there's no benefit from adding telmisartan 80 plus ramipril 10. I couldn't find a signal at all, and there is more hyperkalemia and more acute kidney injury. Now, I would prefer to use a drug like candesartan at high dose than add the two together. There we go. So is he, the patient is, we want to lower his LDL quite significantly. We want to take his LDL down below 2 or have a 50% reduction. Okay. So how should we manage his lipids? We want to give him enough therapy to bring his cholesterol under control. So the SHARP study involved just over 9,000 patients. 2/3 of them were CKD patients and 1/3 were on dialysis. They got the combination of ezetimibe and simvastatin that was available in England at the time. That combination is not available in Canada. Is that combination available in Africa?
No, it's not available. It's available in India, but not in Africa.
Yeah, we didn't have it available here. And the major outcome of the study was cardiovascular, and in particular cardiovascular revascularization. And there were renal outcomes as well. And in the SHARP study, over time, the curves separate after about a year and continue to separate. And you can see from 0 to 25%. And there's a 17% risk reduction of progressing to the major atherosclerotic events, primarily driven by reducing the need for cardiovascular revascularization. So low dose, that's not the way to go. Fibric acid derivatives, that's not the way to go. We just get that out of the way. So we know atorvastatin, rosuvastatin are fine in chronic kidney disease. Simvastatin, less data, and we would want to reduce the dose with CKD stage 4. Ezetimibe is fine. Fibric acid derivatives. These I try to avoid in all patients with CKD. They raise the creatinine. I don't know the mechanism of action. Some of my patients have developed uremia, but I can tell you it's one of the most rewarding things when your patient is on a fibric acid derivative. They're afraid and their creatinine is elevated. Say it's 50% or double normal, and you take them off their fibric acid derivative and their creatinine becomes normal. So we should not be using that in chronic kidney disease. Very few indications for fibric acid derivatives. The bile acid sequestrants are fine. We can talk about those in the discussion. And we'll talk about the PCSK9 inhibitors in just a few slides. Are you using the PCSK9 inhibitors in Africa yet? These are the injectables that are taken twice a month.
No.
Not yet. Super expensive medications, and they've been around for about a decade, and only this year have become available in Canada as part of our drug benefits package for people age 65 and above. But just so you know, these two studies, Fourier and Odyssey, were done with these PCSK9 inhibitors for patients who are at higher cardiovascular risk, and both studies looked at endpoints in patients with chronic kidney disease and found that there was the same benefit to patients with chronic kidney disease in both of these studies as there was for patients without. So they're quite safe for use in patients with chronic kidney disease, but they're really not widely available and they're quite expensive. So if your patient with chronic kidney disease has really high cardiovascular risk, not responding to a statin, ezetrol, bile acid sequestrants, and you're really worried about them, then these agents are quite helpful, but they're super expensive and they're injectable. Okay, let's go on. Donald is pleased that the study he participated in changed the clinical practice guideline, and that he's not pleased that he's now at high cardiovascular risk, but happy that he can just be on a statin and target an LDL less than 2. He tolerates that therapy well, and now his LDL is less than 2. So you mentioned SGLT2 inhibitor before. Is there a role for SGLT2 inhibitors in patients with CKD without diabetes? That sounds like madness, right? Well, it turns out, I won't make you vote on it. It turns out the answer is yes. And this great study that was done by Lambers Heerspink has been completed, and it was presented at the ASN in the fall, which is really exciting. And ADAPA CKD, 4,000 patients whose GFR was 25 to 75. If the GFR was 16 above, they had, and all patients, sorry, had to have an ACR that was abnormal, 20 to 300. So that would be an albumin to creatinine ratio of 300 milligrams per gram or greater. There's another study called EMPA Kidney that is underway, a little bit bigger study, And DAPA-CKD was with dapagliflozin, EMPA-Kidney with empagliflozin, and in the EMPA study, going down to a GFR of quite low, down to a GFR of 20. And there are also some patients without, with normal ACR in that study. So in DAPA-CKD, multi-centered, paid patients 18 above, GFR 25 to 75, their UACR, sorry, not 300, it was greater than 200 milligrams per gram. They get DAPA 10 milligrams, they followed up for almost 4 years, and renal outcomes and cardiovascular outcomes. Just like the Credence study in patients with diabetes, a really dramatic reduction of renal outcomes. Look at the p-value. Can't even count all those zeros. And a 49% risk reduction, sorry, 39% relative risk reduction for DAPA. And for patients without without diabetes, it's a really dramatic reduction. They have a hazard ratio of 50%. It's quite remarkable. And they don't not only have a reduction of renal outcomes, but they also have a reduction of cardiovascular outcomes as well. And it's particularly driven by heart failure. But all-cause mortality also reduced. So the DAPA-CKD study demonstrated that in patients with CKD and proteinuria, that the same as I showed you 2 weeks ago with diabetes, that there's evidence in CKD of slowing down progression for patients who have slowing down progression in these patients. So a patient like Donald will benefit from being on an SGLT2 inhibitor. And indeed, I put him on an SGLT2 inhibitor. Oh, I didn't show you the slide with IgA nephritis, but in IgA nephritis, a sub-study of DAPA-CKD, there was a 60% relative risk reduction, which is amazing. I'm not aware of any treatment for IgA nephritis that has that kind of benefit. So again, just like with diabetes, blood pressure control helps prevent progression of renal disease and cardiovascular disease in patients with CKD. ACE inhibitors and ARBs help to prevent progression of chronic kidney disease and also are cardiovascular protective. And now we have this new class, SGLT2 inhibitors, that not only lower the risk of cardiovascular disease and renal disease, on top of blood pressure lowering and ACE inhibitors or ARBs, but the relative risk is actually bigger than either of the previous blood pressure or blood pressure lowering or ACE inhibitors or ARBs. So very exciting times, and we may be able to really change the outcomes for our patients. All right, I'll leave that up for a minute. Maybe that will lead to some questions, and I will. Okay, let's stop the share, and then we can open it up for discussion.
Yeah, so thank you very much, Professor. And, that was quite enlightening, and really the heart and CKD is an important topic, and I like the fact that you're really kind of focused on how we prevent or decrease the cardiovascular risk, and we're going through the blood pressure target. Of course, we've kind of questioned it in how our setting, how does it apply to our setting. I tend to think that it should apply, but I have a feeling that there will be more side effects, and particularly given the types of patients we have and types of kidney. I don't know, what's your opinion on the oligonephropathy theory in Africa, given the high prevalence of low birth weight?
Yeah, I don't know if that, I don't know. Maybe there's something to it, but there in the SPRINT study, there were enough patients of African origin that it nicely demonstrated there is an equal benefit or greater benefit in patients of African origin. Now, for sure, with intensified blood pressure lowering, I think of it as a journey. Okay, not everybody is going to complete the journey. If the systolic pressure is 160, we may never get to less than 120, but it's a journey. So let's add a RAS blockade, let's add a calcium channel blocker, let's add a diuretic, and then do you want to go further? Do you want to add a fourth agent, a beta blocker or an alpha blocker, hydralazine? Okay, when we start to add more medications, we're starting to get into diminishing returns. But we should target that less than 120. We may not get there. If you look at the recent KDIGO guidelines, managing blood pressure in patients with chronic kidney disease, which I helped to write, I try to describe in some detail there about that journey and encourage clinicians to add up to 4 medications, maybe in nephrologist's hands, up to 5 medications if you feel it's appropriate. But we don't want to cause side effects in our patients. We don't want to make them fall over. We don't want to cause acute kidney injury. We don't want to make them poorer from adding so many medications. So you have to balance all of these things, and that's our job as clinicians. The good news, even though what I've just described is very hard and hard work, we will never be able to be replaced by a computer, because the complexity of what I've just described is beyond what any artificial intelligence program can do, at least presently.
Oh yeah, I wouldn't be so sure of myself. But anyway, yeah. So it's a very good insight. Now, obviously, we went through also other interventions which are possible, including statins and statins in CKD. Yeah, it's interesting why it actually works in people who are not on dialysis, but then immediately after starting dialysis, it's no longer recommended. So would you keep it?
What are your views on the non-traditional risk factors once dialysis starts, and then statins, role of statins? Yeah.
So what happened in the chart, there's a lot of controversy about that. So the 2 studies, the 4D study, and then the rosuvastatin and dialysis study, they just weren't powered enough. And SHARP, the patients, the 1/3 patients were on dialysis at the beginning, but 2/3 were on dialysis at the end. So really, I really believe in using statins in our dialysis patients. I do not stop them when they start dialysis. If you talk to your cardiovascular colleagues, cathing cardiologists will tell you that when they're in there doing a cath in a dialysis patient, there's lots of soft plaque. And cardiologists will treat dialysis patients with statins. So yes, I continue the statin when the patient starts dialysis, for sure.
Okay. Yeah, so if anyone else has a question, floor is open. Really?
Okay,
Yeah,
I have a... Okay, thank you. And I thank the professor for his talk, which is very interesting. But I have a question. Here is talk for the treatment of renal disease and the cardiovascular disease was only focused on medication treatment. What about diet?
Thank you. So last week we talked a lot about diet. So I didn't spend a lot of time this week talking about it, but health behaviors change is the foundation of our treatment for hypertension, diabetes management, progressive kidney disease. So it's critical. But the diet, of course, in chronic kidney disease is a little more nuanced. And we often need the help of a renal dietitian because when we're asking our patients to adjust their diets, reducing the protein in their diet, we don't want them to get protein malnourished. When we don't want them to have a diet very high in potassium because that can get them in trouble. But patients will often feel that with chronic kidney disease, they want to be as healthy as possible, and they increase their fresh fruits and vegetables and cause that hyperkalemia. So it's It's a critical part of our management, particularly sodium reduction, but often it's complex. And I find it's quite helpful to have a renal dietitian involved.
Thank you.
Again, I think, I think in the chat box, sorry.
I know I'm okay. You can continue if there's any comment or questions around here. I had another question. You showed up a table with EGFR 60 plus and albuminuria normal. So if somebody has a 61, a EGFR of 61 and no more albuminuria, when is it a problem and when is not a problem?
That's a great question. So in medicine, we like to lump and split because we can remember things. But human physiology is a spectrum. Everything is a spectrum, a continuum. So that's where we require our art, where it becomes an art of medicine. That's where we require our skill and experience to know, is it time to start therapy for this patient whose EGFR is 61? Or are we going to let them go for a while? Let's say it's one of our colleagues who's come to us and they're worried about that EGFR of 61. They're a 45-year-old male. They're a bodybuilder. Their biceps are 18, 19 inches. Right? That's fine, right? You do a 24-hour urine, you find out that their GFR is really 80 mils per minute. Mm-hmm. But if that patient is, elderly 75-year-old woman who has her GFR has been falling slowly over time, and she's got some you said no proteinuria, that might, that would be a different scenario. You might want to give her a cardiovascular risk reduction. Now, patients who have a low patients who have a low GFR but no albuminuria, the stage G3 or G4A1 is a group of patients that we know very little about. And we just know that they're at higher cardiovascular risk. So we have to go all the way back to the HOPE study to find evidence for managing those patients. And even that patient with a GFR of 61, if she had high blood pressure, she would qualify if she had other cardiovascular risk for a HOPE, to be a HOPE patient, and would have an indication for an ACE inhibitor or ARB. But when you're in that gray zone, we have to use our clinical judgment.
Yeah, I can I can see that. So any more questions? There was one question, Prof. Would you start statin in HD patient with only dyslipidemia? Patient not statin before? I think you kind of answered that question.
Well, but there's a nuance to that. So there's no guideline for that. I would, but it's up to the patient. So I would explain to the patient that it's not mandated, it's not a clinical practice guideline, but I believe that starting a statin in that patient is a benefit. If the patient's lifespan is only 8 months or 12 months, but if the patient is otherwise expected to do well for years and years, cardiovascular disease is their great risk. So I would start it if the patient is in agreement. Mm-hmm.
Yeah, so I mean, there's a lot of new evidence and quite interesting, particularly the SGLT inhibitors. That's just amazing. It's just so painful that it's hardly available in our environment where we actually really need it. When you talk about how many you prevent from going into end-stage kidney disease, it is just very sad. And I really hope that it becomes available quite soon in our setting. Really,
I saw that you suggested that to the NHIF, right?
Yeah, we kind of suggested that, and hopefully that will change. And it's almost like a vaccine for us here. Yeah. But with all this evidence, you find that in the real world, still we are not getting to the standards of a clinical trial, and there's a lot of implementation science research to be done in that, and just the normal quality improvement thing. I find in my practice that patients, when they come to me, they do not know what they are on, and they don't come with their medication. And I don't even know where how to start. There's one a frequent problem I also get is that they'll be in 3 ACE inhibitors. And,
oh my goodness.
Yes, there's some sort of situations where you can see it's, even though you have the evidence, but the quality of care becomes quite an important part to discuss. So we are 3 minutes past the hour. If there's any other pressing question,
There was a question from Ben about extrapolating to young, healthy patients, and I would not do that. I would. I think we should stick to the evidence, unless your gut tells you that you know this patient would benefit and the patient agrees with your plan. But you know, I would not extrapolate SPRINT to a younger, healthier patient.
Mm-hmm.
Supposing you were to do a randomized control trial, ACE or ARB versus SGLT2I, and a combination of both ACE or ARB with SGLT2I, what do you think would be the difference between using SGLT2I against, without an ACE or ARB? I guess there may be no trials that way now, but can it sort of replace ACE/ARB?
That's a great question. So is the SGLT2 inhibitor going to give that great a benefit alone, or does it need an ACE inhibitor or ARB for synergy? I believe that it's synergy, that they should be given together, but we need to do the study to see whether it does its job alone. It's a great question. And thank you for the reference about statins and all-cause mortality in patients on hemodialysis. I appreciate that.
Yeah, so fantastic. That was quite interesting. As always, Professor, we'll really have to ask you to come again and have more talks with you. So thank you very much. Unless there's any other thing, I think we can end here. Thank you.
Thanks so much.
Thank you. That was really wonderful. Extremely grateful having made time and gave us 3 beautiful sessions and lovely sessions. And these slides too, please send the slides. I'm going to email it to everybody. Thank you very much. I missed this. I should have taken it from you before.